Up, we have Dr. Erin Kenny, who's from Montreal but living in Vancouver for about 14 years. She's a proud mother of two awesome kids, and she did a residency here at St. Paul's, I remember those days, back in 2014, and she's worked there ever since, as well as at Mount St. Joseph's. And she's now the physician operation lead for the St. Paul's Emergency Department group. And I must also say that she's, what are you, a brown belt in jiu-jitsu or something like that? Loves, purple belt, loves MMA, and so be nice to her with the questions or she'll kick your ass.
Is that working? Okay. Can everybody hear me? Okay, great. So I'm going to speak today about cervical immobilization. Okay, I have nothing to disclose. And as every good presentation should, I will start with a case. But I do need to give credit to Dr. Avril Isvins from Lionsgate. I don't know if she's here. There she is. For loaning me this case. This is actually a patient that she saw at Lionsgate when she was on trauma. And I'm very grateful to her because I think it provides us an excellent platform from which we can start thinking about the issue of cervical mobilization and whether or not the current standard of care is actually providing the best care for our patients. So this case is a 76-year-old man. He was gardening, turned abruptly, lost his balance, and fell on his back. He was ambulatory at the scene, came in via ambulance in a wheelchair. At triage, he denied having any past medical history. He said he had no numbness or weakness in his extremities, but he did endorse that he was having some pain in his neck, so they transferred him to the trauma room, where they placed him in a cervical collar and laid him down supine on the bed. Very shortly thereafter, he started to complain of new onset weakness and numbness to his extremities. An exam at that point revealed that he had weak grips bilaterally. He had no strength in his lower extremities. He'd lost his rectal tone and he had lost sensation below the level of T5. He went on to get, obviously, urgent imaging that confirmed that he had a fracture dislocation at the level of C7, T1. He was transferred to VGH, where he had a laminectomy, cervical osteotomy, and fixation fusion of his C-spine. But unfortunately, his post-op course was complicated with a delirium. He developed an aspiration pneumonia that required a trach, and eventually he passed away 2.5 months later in long-term care without having gotten back home. So a bit of a spoiler alert, we will talk later on in my presentation about ankylosing spondylitis, but when this patient's history was reviewed, it was noticed that he did in fact have a history of ankylosing spondylitis, and it was very likely the placement of this collar and then the extension of his naturally flexed neck that likely led to his rapid deterioration. So with this case sort of simmering in your minds, let's go back to the beginning. Where did the concept of cervical immobilization come from in the first place? Well, the first publication that advocated for the routine use of spinal immobilization was published in 1966. A group of authors reported on 29 patients who had suffered long-term paralysis post-trauma from what the authors believed was improper handling and then a delay in the discovery of their spinal injuries. They were very clear in their messaging. In their conclusions, they stated that these patients would surely have been protected from their paraplegic conditions had their spine instability been recognized and precautions taken. And this sort of got the ball rolling. The following year, there was another publication entitled Death in a Ditch. And this proposed a systematic approach to spinal immobilization. And it was actually put forward by a trauma surgeon who lived in a small town called Minocqua in Wisconsin, where in the summer months, the population soared from about 2,000 to 30,000. And so all of a sudden, the summer months, the number of car crashes on the highway nearby also skyrocketed. And this trauma surgeon was able to observe what he described as completely ineffective and uncoordinated extrication efforts by the rescue workers there. And so he taught them his own systematic approach and then published on it. The next big chapter in this story is, of course, the introduction of ATLS. So this was initiated in 1978. For those of you who don't know, it was actually introduced by an orthopedic surgeon named James Steiner. And this was after he noted the suboptimal care that he felt he and his family received after a really bad plane crash in Nebraska, and they were brought to the local rural hospital, and he felt that the pre-hospital and in-hospital care was just not where he felt it should be, and therefore he set upon starting ATLS. And within 2 years of it being initiated, the ATLS program that recommended at that point routine cervical spine immobilization for all trauma patients was adopted by the American College of Surgeons Committee on Trauma and by 50 other countries worldwide. And that's essentially the gist of it. In the years following, there was widespread of spinal immobilization of all trauma patients, regardless of mechanism or complaint of injury. And in 1998, 52% of conscious patients who had no complaint of neck patients whatsoever were transported in full spinal immobilization post-blunt trauma. And it may not seem like it, but these numbers have, without a question, improved at least a little bit since then. And this is in no small part due to the development of the two clinical decision rules that we all know and love. Nexus came out in 1998, and the Canadian C-spine rules in 2001. And they were developed to help risk stratify patients who were at high risk for C-spine injury in order to help us determine who needed imaging. But it's now also used in a widespread fashion, both in pre-hospital setting and by us in Emerge, to help us figure out who needs a C-spine collar and who doesn't. So despite these helpful and well-validated rules, we still, however, are left with a whole lot of people who present in C-spine collars. And lately, there's been an increasing amount of debate around this issue. So the way I see it, there are two logic-based sides to the debate. Supporters of C-spine collars believe that spinal mobilization is based on the premise that minimizing movement of the spine will reduce the risk of secondary injuries. On the other hand, opponents of cervical collars believe that damage to the spinal cord and trauma is primarily due to the initial impact, and that subsequent movement, unless there's significant force, is very unlikely to make things worse. When secondary deterioration does occur, people in this camp feel that it typically follows a gradual and perhaps unavoidable progression due to things like inflammation, compression, and hemorrhage, and not sudden provoked movement. So it leaves us with the question, is our long-standing fear in medicine of movement-provoked secondary spinal injury a valid concern, or is it a bit of an ED urban legend? So let's take a look at what the literature says about this, and it'll be a quick look because there's actually only one lit review that has looked at this. It was published in 2015. And they looked to find any published case reports of early secondary neurologic deterioration after blunt trauma. And to summarize, the authors concluded that it was an exceptionally rare phenomenon and really poorly reported in the reports that they did find. In summary, there were 13 papers that had 41 qualifying patients, but only 24 of those had C-spine injuries, so more relevant to our talk today. In the pre-hospital setting, the grand total was 8 patients. And interestingly, all 8 of these patients actually came from one single report in 1986. And also interestingly, none of these patients had a sudden movement-provoked deterioration. They were just noted to have an interval change in their exam between the pre-hospital exam and the in-hospital exam. There was a change. So the authors concluded that from this information alone, sudden movement-provoked injury in the pre-hospital setting remains an unpublished phenomenon at this point, if not a bit of a medical myth. Now, of the remaining in-hospital cases, there were 12 patients who had temporally related precipitants. 5 of these were patients with ankylosing spondylitis who deteriorated as soon as the C-spine collar was placed. And the remainder were a mixture of iatrogenic manipulation, so flex x-rays, for instance, or placement of a halo, or altered level of consciousness. So the most of these were actually intoxicated patients who then went on to have another fall in or around the emergency department. So even though it may seem that sudden movement-provoked secondary neurologic injury in blunt trauma is a pretty rare occurrence, let's still say that our moral compass or our fear of litigation compels us to want to err on the side of caution. Do C-spine collars actually do what they're purported to do in the first place? Do C-spine collars effectively prevent this potential secondary injury from movement? And to be honest, the answer is we really don't know. There's really not a lot of evidence to help us along with this question. A Cochrane review in 2007 showed that there have been no randomized controlled trials done on this topic. In fact, the only published study that involved actual trauma patients was a 5-year retrospective review published in 1998, And this looked at acute traumatic spinal injury patients in New Mexico versus in Malaysia. In New Mexico, they immobilized everybody. In Malaysia, they immobilized nobody. And they found that the risk of disability was actually twofold higher in the immobilized group than it was in the other group. Everything else that's out there is pretty much based on healthy volunteers or lightly embalmed cadavers who have had unstable fractures artificially placed. And the results are contradictory. There are a few studies that do suggest that there's more movement without a rigid collar, but the larger proportion of the studies actually suggest that there probably isn't. One study in 2011 stated that it's possible that the collar is actually creating a bit of a pivot point at the top and bottom of it because they were seeing increased intervertebral movement at those levels. And another study in 2013 that compared standard extrication with a rigid collar versus patients who were able to self-extricate in a controlled, guided fashion. And in the collared patients, they noticed 4 times more movement within the intervertebral area. So again, even though it sounds like secondary neurologic injury may be a highly exaggerated concern amongst our emergency colleagues, and we're not really entirely sure if C-spine collars help to prevent it anyway, what's the harm? If it's a benign intervention, then who cares? Well, the reality is it really isn't a harmless intervention, and the harm is possibly quite a lot. So penetrating trauma is by far the most well-established group of patients in which C-spine collars can do more harm than good. A retrospective analysis that looked at more than 45,000 penetrating trauma patients confirmed that the mortality was twice as high in the spine immobilized patients versus those who were not immobilized. But the potential harm of C-spine collars extends beyond penetrating trauma. As was mentioned in the case that we started with in the lit review that I mentioned, patients with ankylosing spondylitis are at high risk when placed in a C-spine collar. They have a natural flexion deformity, and if they're hyperextended by force into a C-spine collar, a review in 2007 in England that looked at 15 patients with ankylosing spondylitis who were placed in a collar post-blunt trauma found that 12 who were initially ambulatory on scene had rapid deterioration like our patient in the case. So it's an extremely high-risk group. In addition, collars have been shown to increase the intracranial pressure. They've been shown to delay airway control. They've been shown to conceal other injuries like an expanding hematoma or an absent carotid pulse. And then this is actually the study I found most interesting when I was researching this. You know, obviously when you walk by your patient who's had a collar on for 3 hours and they're sitting in bed looking miserable, we all know that C-spine collars are very uncomfortable. But this study took 20 healthy, non-injured, no neck pain patients and put them in a collar. And after 60 minutes, they performed a C-spine clearance and they palpated along the C-spine. And a quarter of them, 5 of 20, reported that they had such significant pain on palpation that the physicians in a real-life scenario would have gone on to get a CT scan. So let's take a look, given all that we've learned since 1978, at what the most commonly cited guidelines that exist today are recommending. And there is a consensus among the big ones. So that's ATLS and PTLS and the American Association of Neurologic Surgeons. And what they recommend is that collars should not be used in penetrating trauma. There is some allowance for experienced personnel to assess if the patient is fully awake, not intoxicated, has no neck pain or tenderness, is neurologically intact, and has no distracting injuries, that maybe those patients can also avoid a collar. But otherwise, the default still remains that all trauma patients with a known or suspected cervical spine injury should be collared. And though that's certainly what we're still seeing here in North America, there are some more progressive changes that are happening elsewhere in the world. There are quite a few countries that have abandoned the routine use of C-spine collars. In the Netherlands, in Queensland, Australia, in Norway, and South Africa, they only use collars for extrications of unconscious patients where emergency personnel can't get into a good position to stabilize the head. So their default is actually to try to avoid using a collar wherever possible. And there are some international committees who've gotten on board with this new way of thinking as well. ILCOR, which is the International Committee on Resuscitation, put out their most recent position statement in 2015 on cervical collars, and they suggest, because of proven adverse effects in studies with injured patients, and the evidence concerning a decrease in head movement only comes from studies with cadavers or healthy volunteers. Benefits do not outweigh the risks, and application of cervical collars is not recommended. And there is a similar sentiment from the Australia and New Zealand Council on Resuscitation, who state that use of semi-rigid cervical collars by first aid providers is not recommended. And in suspected cervical injury, they recommend manual support of the head in a natural, neutral position instead. So in conclusion, I don't want to end my presentation by telling you that you should never use a C-spine collar or you should totally upend the way you practice. I think we all know that widespread culture changes in our profession are normally glacially paced. But we are starting to see change elsewhere in the world, and based on what we know, I'd be surprised if it's long before we start to see change here as well. After all, shouldn't our standard of care be supported by a scientific precedent and not a historic one? Thank you very much.